Good morning. I'm Cate, Vice President for Research, and it's a great pleasure to welcome you to this first in the series of the Grand Challenge virtual research roundtables. These roundtables are designed to provide an opportunity for the researchers who are doing projects supported in part by the Grand Challenges to be able to talk with each other and to be able to talk with their colleagues across the university and with members of the community about what you're learning from your work, about what is important, about what's surprising, and about additional work we need to be doing. So this is like a research seminar, only instead of having an audience full of experts in your field, you're sharing your insights with a group of us who may or may not know something about your particular area of research. This first Grand Challenge virtual research workshop is going to focus on our Responding to the Addictions Crisis Grand Challenge. And again, you will remember this Grand Challenge was launched in a partnership between the university and the governor, Governor Holcomb, and IU Health in an effort to work together to address this critical pandemic that was before the pandemic we all think about today of COVID-19, namely the challenge of substance use disorders that was facing our state and our nation and continues to be a critical issue. And I'll just remind you that one of the really high points, one of the focal points of the entire Grand Challenges program, if I could summarize it in 2 words, are really impact. We want to make a difference. We want to make a difference in our communities and in our state and certainly more broadly, but also partnership, that we believe we can make that impact by working across disciplinary lines and by working across institutional lines. And so that by working together, we can accomplish more by having even the most talented researchers work in a vacuum on their own. So we focus today on the Addictions Grand Challenge, and I want to just start by very quickly thanking Robin Newhouse, Dean of the Indiana University School of Nursing and Distinguished Professor, who is the PI for that Grand Challenge and ably leads it. It is an exhausting task, and she has done so with, again, a team of many colleagues from across the university. And I'm especially grateful that she's giving me the chance to moderate today rather than insisting she gets to do it herself. And I also want to thank Lisa Fukuda, who is the operations manager for the Addictions Grand Challenge, as well as the manager of special projects in my office, and plays a critical role in managing the details, the budgets, the operational side of the Addictions Grand Challenge, and has been, of course, instrumental in getting this set up today. So we're joined today, I'm joined by 4 of our fabulous researchers who are part of this Grand Challenge. And I'm going to introduce them very briefly and then invite them to introduce themselves in any greater detail. There may be experience in their portfolio they want to talk about that's relevant to this, and then to talk briefly about the research that they're doing. So we'll do this alphabetically, but I'm going to introduce them all right away. And that's Matthew Alsma, who is professor of pediatrics and director of the Adolescent Behavioral Health Research Program at Indiana University School of Medicine. Zach Adams is assistant professor of clinical psychology and a licensed health services provider in psychology in the IU Department of Psychiatry. Gerardo Malpome, who is a public health researcher and associate dean of research at the Richard M. Fairbanks School of Public Health in Indianapolis. And then Zemika Zapolsky, who is associate professor in the Department of Psychology at the Purdue School of Science at IUPUI. And that's not why you went last, just that whole Purdue thing. I want to be clear. So anyway, Matt, why don't we start with you, if you will, and take 4 or 5 minutes and give us a little insight into what you're doing.
Great. Good morning, everyone. So nice to be here. So thankful to be able to talk about some of the work that we have going on. And the co-investigators in our project are on this call as well with Zach and Tamika. That's wonderful. So what we really focused on with our project, and it's ongoing, we are not done, is really understanding how to engage youth with significant substance use problems to effective treatment. We've been doing that in 2 counties in Indiana, in Tippecanoe and Wayne counties. We have great partnerships there in the juvenile court system, as well as in the community mental health system. They have really been motivated to move the dial forward to really help young people. And our project is squarely in the field of implementation science. So we know that there are some really good programs in the field to screen youth and to identify them if they do have problems. We know there are some really effective treatments for teen substance use, but to really move someone with need and get them into the right level of care is really difficult. So the guiding overview of that project is called the Substance Use Care Cascade. I'll explain that briefly. So we know that there's this large population of individuals that really need treatment, but at each point of the care cascade, from screening to referral to showing up for treatment to actually completing treatment, the number of youth go down. So the goal of our project, this hybrid implementation trial, to look at effectiveness as well as implementation of these programs, is to really work with the juvenile court system and the community mental health system to bump that substance use care cascade up to get more youth into the right level of care and to improve outcomes for them. So we've had lots of lessons learned in this project. The juvenile court system screens youth well. We've worked with them on that process. They've improved referral processes. We also have worked with community mental health systems to improve the uptake of evidence-based treatment, particularly on the deep end of things. And there's still difficulty. That referral to engagement and care is a problem that we're continuing to tackle. So one really nice aspect of this grand challenge is we've now expanded this project to 8 other counties with funding from National Institutes of Drug Abuse to continue to tackle that engagement problem. So we have some great partners. We've done some really great work. We've learned lots of things. And like a lot of our projects, it's not all done. Thanks.
You know, remembering to unmute may be like the most important lesson of the entire pandemic. Matt, thank you very much. And we will look forward to hearing more in the future as there are more lessons and more learnings that come out of this. So we turn now to Zach Adams.
Hi, good morning. It's good to be with you, and I see a lot of familiar names in the attendee list as well. So good morning to everybody who's joining us from elsewhere. My background is largely in the overlap between traumatic stress and mental health, behavioral health concerns among adolescents, including substance use disorders. So my grand challenge project that we're implementing in partnership with folks here in Indianapolis and all over the place really is related to that intersection. So we know that one of the paths to the development of addiction, substance use disorders, including opioid use disorder, flows through exposure to traumatic injury or illness, as well as exposure to other sorts of environmental factors associated with trauma and adversity. So this project aims to make sure that those adolescents and young adults who are seen in the hospital setting for traumatic illness or injury have some touch point related to behavioral health outcomes. And more specifically, we've adapted and are implementing this model whereby traumatically injured young people are approached in the hospital before they leave, invited to basically view some educational content, self-paced, web-based material about what they might encounter as they recover from their injury. And by the way, some information about some of the medicines they might have been prescribed, including opioids. And they're also invited to enroll in a text-based symptom monitoring program for a couple of months. We know that most folks recover and are doing just fine in terms of their mood and substance use and symptoms after a couple of months. But what we really don't want to do is lose track of folks in those intervening weeks and miss an opportunity, like Matt was alluding to connect them to care. So where are we in this project? We spent the first several months working with our colleagues in the Department of Pediatrics, who have a software development team to build the web-based app and all the pieces and parts that go into that. We also conducted a series of interviews with recently discharged trauma patients, adolescents and young adults, as well as clinicians who work in those settings, just to get a sense of what do we need to be sure to attend to in terms of content, accessibility, usefulness, et cetera. And now we're live and enrolling patients at the Riley Trauma Center and on the cusp of getting ready to start recruiting folks over at the Eskenazi Trauma Center across the street, with the goals being to, one, understand what are some of the factors associated with the development of substance use and mood and PTSD problems once folks leave the hospital. But even more than that, can we use this fairly automated, technology facilitated model to connect people to care efficiently before things, really get bad for them. So that's kind of the gist of the project. Like Matt said, we have a lot of work left to do. We expanded our eligibility criteria to include COVID-related concerns this year, and we're eager to see how things unfold in the coming months.
Super, thank you very much. And we turn now to Gerardo.
Thank you so much. My name is Gerardo Maupome. I'm with the Fairbanks School of Public Health, and I'm going to take a slightly different spin because what we do here is not primarily the research in the classical sense as far as this involvement of the opioid use disorder slant that we have. And that is because Fairbanks has been quite successful in creating a platform, or rather becoming part of a nationwide platform that is called Project ECHO, the Extension for Community Healthcare Outcomes. Extension for Community Healthcare Outcomes. And essentially what it is a platform where clinicians who desire to have more up-to-date information, or perhaps to be part of a community of clinicians or scholars, they join and they seek to increase provider knowledge, improve the skill set to deal with patients with a specific disorder or problem. And also ECHO aims to increase confidence in treating patients with complex conditions. This is something that is perhaps a very efficient way of improving healthcare across the board, not by having these clinicians gathering at conferences or doing something like that, but rather they connect via Zoom at prescribed times, and they have always an interesting part of the conversation being about state-of-the-art approaches, and then discussion of specific patient cases, obviously de-identified, so that there is an opportunity for the leading panelists and other clinicians to chime in and say what would be a good way to address issues with these patients. Now, the Extension for Community Healthcare Outcomes at Fairbanks School of Public Health is not only concerned about OUD. It has several other areas such as how to manage patients with hepatitis C, HIV, LGBTQ, profiles that may be challenging for some clinicians, particularly in more remote areas, in rural areas where updates, maintaining ourselves up to speed with the current criteria for treatment may be more difficult. One of the ECHO projects is precisely OUD, and this is funded by Grant Challenges, has been a very successful type of effort. And we characterize that as public health practice, not so much as research. Although Zach and I and Adam Hirsch and John Agley from IU Bloomington, we're going to start to get the opportunity to squeeze more juice out of the research side of operations. And I guess that Zach will talk about it. Well, we'll talk about it later. But in terms of what we're doing right now is public health practice, and we want to afford this opportunity for whomever wants to contact us to be part of the operations. There's no cost on doing this, and we have had a tremendous response. In fact, I'm looking at the evaluations that John Agley has done of the OUD, and basically we have, from a numeric perspective, very positive responses on how much have they agreed that the session had objectives met. and also very, very positive items about the quality of the presentations. We also have a collection of qualitative remarks about how people feel about this. And generally speaking, obviously we're not going to read all of that, but generally speaking, what is very highly regarded is the empathy of having this community of clinicians being able to talk about their concerns, insecurities, and in some cases with OUD, those are very complex patients. So it is good to have a place that is safe to share, critique, propose, and in some cases just try to figure out how to deal with a situation that is very complex to begin with. So to summarize, the project ECHO for OUD has been going on for quite some time at Fairbanks. We are very grateful for the support we receive from Grand Challenges, and we continue to expand our operations. We hope that we're going to be able to reach out to other health schools in IPY or any other entity within IU if they want to join us as being part of the Fairbanks hub for ECHO. Thank you very much.
Thank you. And we turn to Tamika Zapolsky. Tamika.
Thank you, Fred, and thank you for everyone for having me here. So I want to talk a little about my project. So this was really focused on being able to intervene at an earlier stage of substance use risk. So we know that adolescents generally start using substances around age 13, and that there are risk factors for engagement in substance use, impulsivity, different personality traits, engagement in other health compromising behaviors. And so what we want to do was see if there was a way to be able to provide an intervention for adolescents and actually do that in schools where most adolescents are. Now, pandemic things are a little different of where they're located, but being able to provide it so that we don't have that issue of access to care, like Matt was referring to, that things decrease as you go through that cascade. So we partnered with some local schools to be able to provide an intervention within the schools. It was a 9-week program, group-based, that was based on dialectical behavioral therapy for adolescents. And what DBTA does is teaches 4 basic skills that are really helpful at reducing risk for engagement in many different health behaviors, and also as an intervention that's used for individuals, adolescents, and adults with different diagnoses. But it teaches interpersonal effectiveness, so how to communicate what you need with others, emotion regulation, how to identify your emotions, distress tolerance, how to be able to deal with those emotions without making things worse, and then also mindfulness, which is actually a core component of being able to sit with your emotions, being able to deal with one thing in the moment. And these skills, the idea is by having those skills that it would decrease risk for engagement in risky behaviors and substance use, because you're able to identify your emotions, deal with them, be able to communicate what you need to other people, as well as increasing pro-social behaviors, which is part of DBT. So we partnered with Ben Davis High School, Ben Davis 9th Grade Center, as well as North Central High School, to be able to provide this program to 9th graders. And it was really important to work with the schools and figure out what grade was best suited for this for them. So they did find that they had some programs for elementary and middle school, and then for high school students, there really wasn't many interventions set for this group, as well as there were students that they had identified that there's things going on in their home or things that are going on at school or behaviors that they're at risk for engaging in different behaviors, including substance use, but they were in this kind of influx, this place where they didn't need individual therapy, but they needed something. They didn't need substance use treatment, but there's something they needed and they felt they might fall through the cracks. So we let the school help identify those students they felt would be most helpful for this group. Some of them were using substances, some of them had some truancy or some other issues within schools. Some of them were just the teachers or principals said that this is a child that could benefit from a little extra assistance. So we do a 9-week program that we basically do 2 weeks of each of the skills. And we do that in a group format in the schools pre-COVID for about 45 minutes. We work with the schools too to figure out a time period that works best. So we do 45 minutes because that's a typical class period for students. And also work with the schools to make sure it's not during a core class. So during an elective or a homeroom period, so they're not missing out on their core curriculum. And so we train our staff staff to come in, and we have 2 group leaders and a co-leader that comes in and delivers the intervention to the students. And we have pre-post data, so at the beginning of the intervention as well as at the end at 9 weeks. And we also do a 1-month follow-up, a 3- and 6-month follow-up to see if there's any changes in the our outcomes. So we're looking at changes in the skills, so those 4 core skills, as well as engagement in substance use behaviors, as well as other risk-taking behaviors. And we have found actually really good data from this, from baseline to 1-month follow-up, that we do find decreases in engagement in risk-taking behavior and substance use. And we also look at personality. So I said impulsivity was one of those factors that has been shown to be increased risk for engagement in substance use and risk-taking behaviors. And those students that were higher on our impulsivity measure actually had a more significant decrease in their outcomes, and that was significantly different from also control. So we work with the schools to get the same pre-post data for adolescents that are in the health class at the schools. So that's treatment as usual in this setting. So we're able to see, different from what adolescents are generally getting in the school, is this intervention helping. Just to let you also know, we do exclude youth that are in some other treatment at the same time, so that there's that confound there. So we found it to be really helpful. Moving forward, things change with COVID, with the schools, a lot of things going on. We did move online this last semester and are still working with the schools. Even with everything going on, they want to continue. And what we have found is that the schools are very interested in this program. The students, particularly when we were in person, the word will get around. And so we have so many students that are identified by the school each year to participate, and we actually run out of space to be able to provide the intervention just with our staff. And so we have been working now to be able to train staff members, or working on a way to train staff members to be able to deliver the intervention, moving forward, to see how that would work with disseminating and implementing the program that way. As well as working on adaptations to the program, particularly with the racial unrest and issues also with bullying. We are working on an adaptation that is going to provide more explicit discussion on coping with bullying and discrimination, as well as what to do if you witness it from someone else and how to intervene.
Great, thank you very much. Amazing work. And let me just say, so we put it on the record, amazing, 4 researchers who all stayed under their time. It's a fabulous thing. So there's a lot I'd love to talk about. And by the way, we'll be taking questions from the audience as well. You can enter those into the Q&A box, and those will be collected, and then we'll turn to those as we get closer to the end of the hour. But Tamika, let's start with you if we may, but it's really the same question to everyone. So you're working in each case with particular target audiences. I mean, in your case, students in school. And I'm just curious how they react to this. Like, are they terrified when they're offered this opportunity? Are they think it's great and it's something they think they need? Are they reluctant? I'm curious. And I would ask the same question for all of you, including Gerardo, in your case, working with other caregivers. Do they welcome this, or is this something that they're like, oh my God, not another thing, and you have to persuade them of the value of it? But Tamika, to start with you.
Sure. So, adolescents are, some are excited and realize they need some extra assistance, and some say, nope, I'm good. And so those that don't, we don't pressure them to do it. We find that interventions work best when you have buy-in and the person is ready to engage. So we do have some youth that at the beginning, we present what the program is. It's not presented as a substance use treatment. It's presented as it's called goaling for goals, because we help them identify goals to reach across the course of the semester, as well as emotion regulation and things like that, to be able to manage stress and deal with other people. And so that's how we present it to them. And so some kids, again, are good, but others realize they do need some extra help with that. We do find, though, that like I mentioned, when we get through the group, the word gets around. And so other students actually ask to be part of the group, ask to do the group again. So that's why it has worked so well in the schools thus far, is that we have really good buy-in from both the staff as well as the students that want to participate.
That's great. That's terrific. Gerardo, how is it when you're dealing with healthcare professionals?
Well, I think that we have a privileged position because, quite frankly, we provide useful, actionable information for them. So that's an easy sell. Our clients are very happy to have that opportunity in exchange for 1 hour of Zoom in the schedule every 2-3 weeks. So I think that if anything, we have a great position to have people who are interested in the tools. They have the opportunity to apply them fairly quickly. And they also, as I said before, they're grateful for the opportunity to belong to a community of like-minded clinicians who want to have good information about a specific profile of patient or client that they need to address. Now, it is very much to the credit of Andrea Janora, the director of the ECHO project at Fairbanks, that we have a really nice, smooth operation thanks to her and her team. But in reality, it really has to do with us offering a simple, useful, actionable, free system that is also having the extra opportunity to get some continuing education credits. Our clients are primarily physicians, but there are all sorts of care providers that connect to different types of ECHOs. And I have to say that because we care much about the content expertise in each one of these ECHO projects, we have people who really know very well the way around this. In fact, Zach is the leading content expert for the OUD ECHO, and he would like to, perhaps he would be well positioned to offer more insight into how to make these resources attractive to clients.
Go ahead, Zach, please.
Sure. Yeah. So, well, I guess to pick up on the ECHO point, so we have, I guess, a complementary program housed in the School of Medicine, our OUD ECHO, and some related programs focused on teen vaping and child and adolescent mental health and so forth that really do round out this content set. And when we think about who ought to be around the table when we're talking about the management of a complex disease like opioid use disorder, of course, we're thinking about addiction psychiatrists and behavioral health experts, but we're also thinking about attorneys and judges. We're thinking about peer recovery coaches. We're thinking about folks who can really provide some specialty knowledge around all of the pieces and parts that are relevant to recovery more generally. So, we're fortunate within the university to have a lot of that expertise. Of course, we partner with a lot of folks around the state and the country to make sure that we're meeting the need as it exists. The other thing that's really important about that model is that there's a strong emphasis on this notion of all teach, all learn. So while we bring some content specialists and experts to the table at the hub team, really, it is not disingenuous to say that all the specialists are learning from the participants, because what the conditions look like on the ground in Evansville are very different from Westport, Indiana, very different from Gary, and so forth. So knowing more about the local and regional models, the needs, et cetera, also help us to think, for those of us who are researchers, what are the gaps? What do we need to develop that might look different? What needs to be evaluated? What are innovative programs that could be rolled out? So we've, in our programs, we've not struggled around attendance. In fact, I see Kristen Kelly, one of our coordinators, is on here, and she does a fantastic job also of spreading the word and recruiting folks. But we're always really pleasantly surprised, especially in our first couple of sessions every time we launch the series, that folks show up. And it's because there is such a need in the community for this type of support. Pivoting a little bit to the other project or program, the question you asked, I think, is exactly why we did some of that formative work interviewing recently discharged patients and healthcare providers, because if nobody wants this, or if there are major sort of concerns or barriers, we ought to know that on the front end before we put a lot of time and energy and resources into launching something. So the feedback was positive from those initial interviews and surveys. And while we're in the early days of implementing this, one of the things that I've been pleasantly surprised by, I mean, we invite these adolescents to receive a text message every day about their mood, their stress level, their pain, their sleep, and their substance use. And in some ways, we're interested in the responses, but almost more than anything, we just wanted to have a touch point where we're staying, in contact, so that, a few weeks out when we reach out, they have a sense of who we are. Well, of the folks who are engaged and enrolled in the program right now, I think the response rates for how many texts they're responding to are close to 90+%.
Wow.
They're responding every day. So it makes me think, gosh, maybe we're not doing enough in those small moments. We do provide some tips based on their response each day. So maybe there's some other opportunities we could leverage. And, one last thought before passing the baton again is that, you asked about partnerships and so forth earlier. And as has already been mentioned, there's lots of points of intersection even within our group represented here. But I think several of us are also using the computer adaptive test suite that Dr. D'Onofrio and his team in Bloomington have been rolling out and evaluating. And we've baked that into this project too, where periodically, in addition to those texts and so forth, we're seeing, gosh, could that computer adaptive test assessment that gives us a very rapid read on somebody's PTSD, depression, substance use, could that be useful here? And might there be other contexts in which we could use this platform besides the trauma center to stay in touch with folks in between maybe more formal system contexts? So anyway, just a few thoughts on acceptability and partnerships and where things might go.
Yeah, but really, I mean, I don't know whether to be uplifted by the extent to which people are embracing this, or depressed by the fact that there's so much need, that they are so eagerly welcoming it, that obviously what you're all talking about is filling a critical need. Matt, let's give you a chance here. Are you also finding enthusiastic uptake?
So I think there's two parts to that. One is for the research project, and one is for substance use treatment. Right. So if you think about where we're recruiting youth, it's probably one of the worst days of their year, maybe even life. They're arrested, they're brought to an intake center, their parents are then called to pick them up, or they're placed in detention. That's a tough, tough, tough day for everyone involved. So at that point, we have some youth that are really motivated to change, to never be back in this environment, and they're open to treatment, to doing anything that they can. And then we find some youth and parents that are completely overwhelmed. Their child is not going to school, they're involved in the criminal justice system, there's substance use, there's difficulty in the home, they now have things they have to do for court. So we see the spectrum in terms of interest with the research project recruitment, as well as treatment in general. So yeah, lots of stuff going on with them. And we're really excited, and we have been really privileged when we do get people interested in the project. And we're excited when they do engage in treatment, because there's some good outcomes there.
So one of the things which I'm particularly interested in you as researchers is what has most surprised you as you have initiated these projects. In other words, and it doesn't have to be profound. In other words, it can be profound. That's great. Profound things are welcome. But sometimes it's really much more basic things that were, I never knew this, or this completely shocked me, whether about working in this environment or doing this type of work, or the particular research that you're doing. And I'm just interested. I don't know, maybe Gerardo, we could start with you.
I must confess that I did not initiate this project. It's very much to the credit of Dr. John Duvey, that she was in charge of the project conception and development. Unfortunately, she had to move to South Carolina to become the medical health officer there. So I really received that initiative already implemented and in good shape. In becoming more familiar with the features of the project, I have to say that to me, it was very striking that there was so much need. with the horrendous implications and the problems of the epidemic of opioid use, that there were so many clinicians that were in some cases really at a loss on how to deal with this effectively. And I'm not really sure we're seeing the complete set of needs, because there may be some others, and including people who are not in the clinical care, but in managing this problem, this disorder from a different angle, that have not reached out to us. So if this is the tip of the iceberg of those that realize that they need better information to address the challenges, I think that there is a tremendous amount of need out there in order to have less of the prejudices surrounding this type of addiction problem and more of an active, enlightened, educated, resourceful way of helping people that are really in tremendous need. So if anything, we should be having more and more people besides the substantial attendance we have, but hopefully we are apparent enough out there in the landscape so that whomever thinks that they can improve their information about how to address these challenges, they actually reach out to us.
Okay, thank you. Tamika? Surprises?
I think echo what Gerardo said. I think it's the need. I knew that it would be something that would benefit youth, but I wasn't prepared for how many students will be referred to us, and being on the other end of not having the staff and the hours to be able to accommodate was something that was, I guess, surprising to me, as well as just I assume that there was, other programs that would have been provided that would have, already also been implemented, and just the lack of other evidence-based practices that are available in the schools for them. And then just thinking about time. I know schools are always crunched to fit everything in, and having to be the needs for kids for so many different issues. But I was happy, I would say, just how welcoming the school was to work with us and to be accommodating to try to figure out how to make this work. And it has been really, really great partnership.
Well, and it sounds like in your case, and frankly, in a number of these cases that we've discussed, you're providing a service as part of your research that is not just limited to opioids or even substance. I mean, in other words, helping adolescents learn to manage, frankly, helping adults learn to manage emotions would be an enormously valuable service, whether or not there was a substance use component.
Yeah, and we actually also have teachers asking, "Oh, can I do the program as well?" So, so it's funny.
So Matt, let me turn to you on the same question about the things that may have surprised you or struck you as you've been doing this.
Yeah, I'm sure everyone on the call can talk about COVID and the need to shift. I know in Wayne County in particular, they're a little more rural than Tippecanoe County, and just the incredible difficulties families have with accessing care, education during a time of COVID, and just not having internet, having to go to a library to get remote internet, and just the extent that families will go to get some of those services that they need, and all the barriers that are there. It's just not right. So COVID, lots of shifts for community mental health, for juvenile justice, and of course for the research.
And Zach?
Yeah, well, we're definitely in the early days on the data collection front, so it's a little tough to speak to something that's been revealed by the data per se. But I think one thing that has been exciting about this project is really recognizing how many different investigators, clinical service lines, community organizations, et cetera, really have overlapping goals and objectives with some of the work we're doing here. And I'm seeing one of the questions in the Q&A box about applying some of the work we're doing to unhoused population and thinking about adaptations of these platforms. I'm thinking like the software we've developed is not specific to trauma patients or implementation in a hospital-based setting. It's a framework for implementing these technology facilitated assessment tools, essentially. So it doesn't matter where folks are the educational content could be adapted, and we could think about using that same, infrastructure to reach out to folks in all kinds of different settings. That's one of the most exciting things, I think, from this project is being able to think a little more broadly than my individual lab or this individual project. So yeah.
Thank you. And so just before we turn to questions from the rest of our participants, I just want to ask you about the extent to which we see the impact of the enormous controversies over the summer and certainly continuing into the fall over race and racial justice. We've I think long known, one of the things I have learned as we have rolled out this grand challenge about the importance of so many factors, economic factors, social factors, that influence the likelihood someone will become involved in a substance use disorder. But I'm just interested in how both the substantive question about social determinants, but also the practical question for you as researchers dealing with these issues at a time when race has become such a more prominent part of our discussions, and to what extent that's influencing you. And Tamika, I think you mentioned this earlier. Maybe we could start with you if you wanted to follow up on what you were saying. But I'm just curious. I mean, COVID is one obvious thing that's been going on, but it's not the only one. So.
And that's always been a part of my research program, is to figure out how to make my programs culturally adaptive to be explicit about discussion of race, racism, as well as other forms of discrimination within the work I do, because the other half of my work looks at risk models, primarily
Right.
among minority populations, and looking at sociocultural factors. So there's strong evidence on the impact of these type of stressors on health outcomes, both physical as well as substance use outcomes among minority populations. So that's what we're doing, is figuring out now the best way to be explicit about discussing that. Again, something that particularly minority youth are experiencing is nothing new. It's not going to be a shock to talk about it. But I think setting up in a way of also now knowing you have allies and how to prepare other people to stop doing it, or to be able to intervene if they experience it, and not put the onus on the person as the victim to be able to just cope with what's happening.
Okay, thank you. Others on this question?
Well, I would make the comment that
Yeah.
we have these issues of unequal access to resources to meet the challenge of the disease. But I think that in this context, and knowing what ECHO is about, but many of the features of the OUD is that rural populations and or poor populations are very markedly affected by this problem. So the kind of research that we do and the kind of services that we provide are probably trying to even the playing field, so to speak, so that people who are tremendous need are brought to reasonable access to standard of care that is acceptable. So it's an important issue. In terms of the what kind of profiles we have here, we know that there are some disparities as far as racial and ethnic groups are concerned. But in fact, the research project that Zach Adams, Adam Hirsch, John Agley, and I are putting together, hopefully for March, for my submission to NIH. Zach is smiling. I don't think that's a good sign, but we're trying to get this thing out.
It's not a bad sign, Gerardo.
Oh, okay. So you
at least he's not crying.
Yeah.
So
okay. So that's true. He's not crying. So I think that we're still in the game. And what we're trying to do here is using an objective measure of how will go ECHO to improve the performance of clinicians when it comes to dealing with cases of OUD. And we are borrowing heavily on Adam Hirsch's prior work, which is primarily comparing whites and blacks about prescription of painkillers in the medical setting. But the one thing that we want to do in this context is, instead of assuming that more knowledge becoming part of an engaged community of clinicians is going to lead to better outcomes, we want want to quantify those outcomes. First, in terms of the knowledge that is derived from being part of ECHO. That, to a certain extent, has been already quantified thanks to the evaluations from John Agley. But when we look at the clinical elements, such as the number and type of painkillers prescribed, prescriptions, other quantifiable outcomes, and certainly at the end of the day, whether health systems see a reduction in waste because the prescriptions and the management of these patients is better, this is when we want to create, okay, the before ECHO, then ECHO, and see what happens later. And I have made my case for being funded, so Zach, we're ready. Thank you so much.
Zach or Matt, any comment on this?
I mean, I think clearly whenever you work with the criminal justice system, we know time and time and time again that young minority youth are overrepresented at every point in the criminal justice system. So clearly, with everything going on with George Floyd and just acknowledging that we all have to do better at the very front end of the system with police, to the very deep end with Department of Corrections and in a federal setting. In Indiana, the juvenile justice realm is doing good work there in terms of really limiting detention of youth, and it doesn't stop. Even when we saw the rates of jails going down in detention, we saw that it was disproportionate. So young African-American males were more likely to stay in jail, while majority young men were more likely to be released. So that just all says we have to know the data, we have to advocate, the work does not stop, and there's more to do.
Thank you. Shall we open up the to take questions from the audience? Lisa, do we have questions?
We have had some questions, but they have been answered live by our researchers already.
Perfect.
So we certainly open it up to more.
It's that multitasking ability I think is so impressive. While those are coming in, can I just ask? So on the one hand, this is there's a lot to be depressed about. I mean, substance use disorder is an overwhelming issue. There are, it's like pulling a strand of yarn and a ball of yarn. Every time you think you've got something, then it unravels a little further. I mean, there are huge economic issues and there are huge racial and other issues, urban versus rural, and then COVID on top of it. And yet you are doing amazing work that in each of your settings seems to be either visibly making a difference, you can already measure that, or has the promise for making a difference. So I'm just curious about your personal outlook as you look at these issues. Do you feel hope? Do you think we're getting better? Is research driving towards a better place? Or do you feel overwhelmed, like this is like trying to empty the ocean a teaspoon at a time? Don't depress me here. Matt, why don't we start with you?
Yeah, I was going to say, if you point to Zach, maybe he'll start crying at that point. No, I would say for our work, I definitely do feel hope. I mean, in both of our communities, you see a very activated juvenile justice system really stepping into this space of trying to help young people, and community mental health centers that are really trying to do great work. Now, that doesn't mean the barriers don't stop with turnover with staff, unique issues, COVID, the rural issue. But when you have really strong champions willing to step into that space and drive change, it's helpful. And there's really great state partners as well, whether that's in the opioid crisis, Doug Hunsinger, some of that group, JDAI, Juvenile Detention Alternatives. So really thankful for that county and state leadership.
Well, and I would just add to that, I mean, I've been really impressed. I mean, the Indiana Chief Justice Loretta Rush has been unbelievably committed on this issue, and a leader both in the state and nationally, and kind of that no nonsense leadership, like bring me things that work or get out of my way, because I'm not interested in just talking about it or issuing press releases or holding meetings. So anyway, Zach, are you crying, or are you upbeat?
Yeah, well, I think there's a lot of reason to be hopeful in this area. And I think it's, like so much of any health related research, we're out to solve big problems, and there are a few that are bigger than the problem of addiction. And I think that, Matt highlighted a lot of reasons to be optimistic, in terms of the work we're doing here in Indiana. Um, a lot of us focus on youth populations, and I think part of, for me, what drives that is this opportunity to bend trajectories away from, all of the really horrible outcomes that we hear about. And another of my, jobs is to work within the adolescent dual diagnosis program through Riley at IU Health. And in that work, we see kids who are really having a hard time. Not a lot of self-referrals, a lot of kids who don't want to be there. They're against a lot of really tough circumstances and situations. And in the course of just a few months, we can see some really dramatic improvements in the quality of their life that we think to be durable over time. So, the good news is we have, for example, some treatments that work. There's a lot of room to improve sort of the menu of options, especially around behavioral interventions for young people and medications really for everybody. But there's also, I think, a lot of opportunity to improve getting those interventions to the people who need them. And that's a lot of what we do. And we've seen some success in that. So those are some of the things that, make me hopeful.
Great. And Gerardo?
Well, I won't speak to the specifics of how things are changing, because that's really not my area of research to the extent that I will be able to speak with the same level of authority as Zach, Matt, or Tamika. But I will speak to a public health aspect of this, and that is that I think things are getting better. It's like an ocean that if it is not emptying, at least it is not getting larger. And part of that really has to do with the structural changes that we see, with better regulations about painkillers, with legal action against the people who are probably at best called imprudent and at worst criminal in their behavior on how to market and create this painkiller epidemic. But I will also say that we need to become far more responsive on how we look at the overall picture, how this is prescribed, how these items are making it into the hands of vulnerable patients or people. Case in point, in my own profession as a dentist, I cannot find a real justification for every time that we have a young person having thermolars extracted, they get a stack of Vicodin to take home so they can start getting hooked on that kind of thing. Honestly, there are better ways to manage that, and the dental profession is waking up to this type of thing. So you see that this change is happening to the extent that I would like to believe that things are not getting worse. They're already pretty bad, but they are not getting worse because the environment where these things allowed for things to get out of control has changed enough to at least contain, to a certain extent, some of the driving factors to make these things bad enough in the first place.
Thank you. And Tamika?
So I am lucky enough that we do qualitative interviews with the students and the staff at the schools to see what they like or don't like about the program. And so through those, we get a lot of rich data on what they are benefiting, even outside of the classroom, with their families, with their friends. And so that gives me hope, right? Even if we're helping one student, it's enough. But also to hear the school talking about, or teachers talking about, changes that they see across the board with some of their students. And then it then hopefully goes to a change in the culture in the school, how they address it, teaching, hopefully at some point, teachers how to be able to use those skills as well in the classroom to help students that are taking the program as well as those that are not, and teachers as well as being able to help manage their own stress levels. So I am hopeful for this. I also am hopeful when talking about even the adaptations with some of the schools I've already talked with, that the teachers have come to them already saying, I want to be able to address racial injustice and inequity and learning these skills and things like that to teach the students, and as well as other schools that have hired other mental health workers our staff to specifically address social emotional learning and address DBT. So there are systems in the schools and people in the schools that are also very active at trying to move the needle, which gives me hope and promise.
Great, thank you. So I think we have time for just a couple of questions, and some have come in the Q&A. So I'll hand it back over to Lisa. I will also say somebody has asked, can we post the websites for all of these projects? And we can do that. I see you're posting them now, and we can also circulate them to everyone who registered to attend. And of course, they're on our website at the Addictions Grand Challenge. But Lisa, let's see if we can sneak in a couple of questions here.
Sure, there's one here on stigma that I'd like to hear your views on. So there's significant stigma still associated with mental health and addiction issues that prevent healing. Can you share your perspective on how addiction can be thought of and treated as we would treat other physical disease such as diabetes?
I'm gonna leave this up to you. Who would like to speak to this?
Stigma is significant. I think there is a surprising amount of stigma on the treatment side. I think at least in the adolescent realm, in general, we're seeing some therapists that are more confident around treating mental illness than addiction. So I think that's where outreach training around addiction treatment with teens, that we need to step into that space more for Indiana. And I think having that lifelong perspective on addiction is so important. So that is a significant issue to continue to raise, and treatment providers, courts needed to grapple with that. How do we do that, Zach?
Yeah, it's a big question, but I will say that one thing that is encouraging, on the heels of our prior comments, is that there do seem to be rather multiple efforts really aimed at this issue, and where the message is tailored to different audiences that matter. And I'm thinking about the comment Matt just made. Law enforcement may have different stigmatizing or discriminatory views about folks who have opioid use disorder and other forms of addiction than do folks who are working in a health clinic, than do for folks who have a family member who might be diagnosed with an opioid. So I think there's something to understanding what the various forms and sources of stigma and discrimination might be. Thinking about some of the work we're doing, there's one sort of approach, which is to try and reduce stigma and improve more sort of better understanding of the disease of addiction and so forth. And then there's another sort of tack where you say, okay, well, we know that there is stigma and we know that there are some of these factors at play. How do we design systems that help get around that a little bit? And I think some of the technology facilitated monitoring and connection to care recognizes that somebody might not feel comfortable or might have some cultural views about seeking out mental health treatment or substance use, whatever the case might be. And if we can provide an avenue that's maybe less stigmatizing or has more capacity for anonymous connection or whatever, that we're also, I think, being attending to some of those concerns. NIDA, by the way, has tons of resources. The state Know the OFAC's initiative has a number of resources. So, happy to point people in that direction too, if they're looking for content and material.
Anyone else on this question? Okay,
just a quick
please.
comment that I think is going to be also in the same line of thinking that Tamika has shared with us, and that is that the stigma operates differently in different racial and ethnic groups. So it is actually quite commendable, any kind of effort that looks at stigma from a cultural lens, so that we ask the right questions and we take a stigma with the right kind of perspective, because it simply means different things. I can tell you that in the case of Hispanics, talking about mental health is taboo. I mean, you have a mental health problem, oh, you're crazy. I mean, there's nothing in between. From zero to crazy, there's no level in between, which is a huge problem, of course.
Thank you very much. We are not going to, I don't think, have time for another question. We're right at the top of the hour. So let me just take a moment, first of all, to thank our 4 panelists who have just been amazing, and not just as panelists, but as researchers who are doing such important work as part of this grand challenge. I am grateful, and I know I speak for all of my colleagues in the university in saying thank you for both doing the work and for sharing it today. I also want to thank the people who joined us on this call, and we will be doing future meetings like this at least once a month in the days ahead as a way to expand activities and access to the information from our other grand challenges, as well as returning to this one. And once again, thank Lisa and her colleagues, April Toller and Anna Velasco, who have been critical in setting this up. I'm extremely grateful. I wish you all very happy holidays, and thank you again. Bye-bye.
Thank you.